Hello, everyone. I'm Dr. Katherine Tuttle, Executive Director for Research at Providence Inland Northwest Health and Professor of Medicine at the University of Washington. I'm pleased to give a presentation to you today titled How to Implement the New Guidelines for Treatment of CKD and Diabetes, What You Need to Know. Here are my disclosures. Our goals today will be that by the end of this presentation, you will be able to describe the scale and risks of chronic kidney disease and diabetes, define the evidence for guideline-directed medical therapies to reduce kidney and cardiovascular risk, and discuss overcoming barriers to implement guideline-directed medical therapy for CKD in persons with diabetes. So I'd like to set the stage by asking the question, what problem are we trying to solve? There are 537 million people worldwide with diabetes. 95% have type 2 and 5% have type 1. 4 out of 10 with type 2 and 3 out of 10 with type 1 diabetes will develop diabetic kidney disease, making it responsible for half of all chronic kidney disease worldwide. And while the traditional focus in nephrology has been on progression to kidney failure, the truth is that because of the enormous competing risk of death, primarily from major cardiovascular events, including both atherosclerotic cardiovascular disease and heart failure, 9 out of 10 people will die and never make it to kidney failure. This is really a survivor cohort. In fact, you might say, congratulations, you survived if you make it to dialysis. So when we think about the totality of risks of kidney disease, we really need to focus on addressing both the kidney and the cardiovascular risks. With that in mind, the diabetes and CKD guidelines from KDIGO, most recently updated in 2022, now recommend that SGLT2 inhibitors, along with the traditional RAS blockers, such as an ACE inhibitor or ARB, are first-line therapies, along with statins for cardiovascular risk reduction and metformin, if needed, for glycemic control, and if GFR is adequate. On top of this, we recommended additional risk-based therapy. Risk-based therapy means regular risk factor reassessment. So even after starting initial therapy, risk factor reassessment, including GFR and albuminuria, along with conventional risk factors such as blood pressure, lipids, and glycemia, should be remeasured every 3 to 6 months. And for patients who have residual risks, for example, persistent albuminuria, we would recommend adding a non-steroidal mineralocorticoid antagonist. For a person who needs better glycemic control, a GLP-1 receptor agonist, and antiplatelet therapies if needed for atherosclerotic risk reduction, all in the company of conventional risk factor control to reduce the totality of kidney and cardiovascular risks in this very high-risk population. I'd like to show you a little bit of the background of how we came to these guidelines. The sodium glucose cotransporter 2 or SGLT2 inhibitors came to our attention through the cardiovascular outcome trials. These were mandated by the United States Food and Drug Administration in 2008 after the so-called rosiglitazone debacle, where that glucose-lowering agent, once on the market, was reported to have a number of adverse cardiovascular side effects. So the regulatory agency made a determination that for a new glucose-lowering agent to stay on the market, the sponsor would have to do a post-market approval cardiovascular safety study. These truly have been the gifts that keep on giving, because not only were these agents safe, but they were highly effective in reducing risk of major cardiovascular events, predominantly heart failure with this class, but also a reasonable benefit on atherosclerotic risk reduction, and 2 agents in the class, empagliflozin and empared, and dapagliflozin in the DAPA heart failure trial, also reduced cardiovascular deaths. Importantly, for the kidney community, the major secondary outcomes were kidney disease outcomes. And across the board in these cardiovascular outcome trials, SGLT2 inhibitors decreased onset or worsening of macroalbuminuria, GFR decline, and kidney failure. And these kidney and cardiovascular benefits were present even in the very high-risk group of people who already had CKD. This quickly led to what we call the trilogy of the SGLT2 inhibitor trials for chronic kidney disease. So these studies had primary kidney disease outcomes. Every single one was stopped early on clear evidence of benefit. This was a first in nephrology. Clinical trials had been stopped before for futility or safety, but never for overwhelming efficacy, which is a very high bar to cross. The trials done in sequence were credence, all type 2 diabetes, GFR of 30 or higher, and UACR over 300. Next, DAPA-CKD extended the population to 1/3 without diabetes, dropped the UACR lower limit to 200 and GFR to 25. And then IMPA-Kidney was the broadest population study with a GFR as low as 20, irrespective of albuminuria, and more than half did not have diabetes. And what you see across the board is the hazard ratio for the relative risk reductions were very similar in the range of 30 to 40%. However, when the red arrows at 30 months are the residual risks in each of these studies. So while there was clearly clinical benefit, there still are people who are progressing and having kidney disease events. So the job isn't done with simply an SGLT2 inhibitor. Enter the GLP-1 receptor agonist. These agents were studied in exactly the same format as the SGLT2 inhibitors for cardiovascular safety. They've been another gift to us. Yes, they reduced risk of major cardiovascular events, as well as were safe. And the main benefit here is on atherosclerotic disease. And two agents in the class, liraglutide and LEADER, and semaglutide and PIONEER-6 reduced CVD death. Similar to the SGLT2 inhibitors, the clinical trials had kidney disease outcomes as major secondary outcomes, and across the board. They too decreased macroalbuminuria, onset and progression, and slowed GFR decline from early to even late stage CKD, with at least 3 agents in the class, liraglutide, dulaglutide, and semaglutide. And these agents, in contrast to SGLT2 inhibitors, are highly effective glucose-lowering agents, even in advanced CKD, and they've been studied in populations with GFR as low as 15. And again, the kidney and cardiovascular benefits are present even in the patients with CKD who are the highest risk subset. So until May 24th of this year, that was the current state of the art. Then came the FLOW trial. The FLOW is the first dedicated kidney disease outcomes trial with a GLP-1 receptor agonist in type 2 diabetes. This was another trial that was stopped early for clear positive efficacy. Hazard ratio was 0.76. And down the line of confirmatory secondary endpoints tested hierarchically, it hit every one of the endpoints. It hit the composite kidney outcome, GFR slope, MACE or major atherosclerotic events, and perhaps most importantly, reduced risk of all-cause mortality. Here's the data from the primary outcome. This was greater than or equal to 50% GFR decline, kidney failure defined by GFR less than 15, initiating chronic dialysis or a kidney transplant, or death due to kidney or cardiovascular causes. And here you see the hazard ratio of 0.76, 24% relative risk reduction. And at 3 years, the number needed to treat is just 20. What about cenerenone, the non-steroidal mineralocorticoid antagonist that has been studied in persons with type 2 diabetes and CKD? There was a pair of trials, FIGARO and FIDELIO. FIGARO was done in people with less severe CKD who were at higher risk of cardiovascular events. So the primary outcome of FIGARO was a cardiovascular outcome. In contrast, FIDELIO was a higher risk kidney disease group with higher albuminuria and lower GFR. And in that study, kidney disease outcomes were the primary outcome. They pre-specified to meta-analyze these two trials together. So this is called the Fidelity meta-analysis for kidney and cardiovascular events with cenerenone versus placebo. There were over 13,000 patients in these trials, followed for a median of 3 years. The CVD outcomes that include MACE and heart failure had a hazard ratio of 0.86, highly statistically significant and mainly driven by reduction in heart failure events. The kidney disease outcome, you can see here, 50% GFR decline, which is the equivalent of creatinine doubling, kidney failure, and 50% decline all contributed to the benefit on the kidney outcomes. And this held up even with using a 40% decline GFR threshold. And it just missed statistical significance for all-cause mortality with a hazard ratio of 0.89. In this analysis of the Fidelity trial, now limited to the high-risk kidney patients, George Bacris and colleagues published this analysis showing that across ranges of GFR, from higher to lower, and same on UACR from lower to higher, so higher risk patients, that the hazard ratio was similar across the severity stages. But note that the absolute risk is highest in the people with the lowest GFR or the highest albuminuria, yet the absolute benefit was even greater here because the relative risk reduction and a higher absolute risk reduction leads to more benefit. So the point here is that all stages of CKD benefit from finerenone, and we should particularly be focusing on initiating these therapies in highest risk patients because in total, they have the most to gain. And this is a reminder that when we assess CKD in diabetes or in other conditions, we need to check both albuminuria and GFR. Both contribute to the risk stratification shown here as a 𝘊𝘰𝘯𝘧𝘰. And moving down in GFR or moving right to higher levels of albuminuria increased risk. And note that the recommendation is by the time people are in red boxes that are very high risk, not only should treatment be initiated, but the recommendation is they be referred to nephrology because these people are likely to need multi-drug therapy that will require subspecialty support. Whereas at less severe stages, many of these people can probably be managed in primary care or non-nephrology practices. And remember that the risks are not only losing kidney function and kidney failure, but also cardiovascular events reflected here in this risk grid. And we need to address both in order to holistically manage patients. Now, unfortunately, the vast majority of people with CKD are unaware. Only 7 to 20% who have CKD are actually aware. And among them, we see that there really is suboptimal care, whether it's proteinuria monitoring, achieving blood pressure or A1C goals. RAS inhibitor use didn't look too bad at 70%, but we'll take a closer look at actually what that means. Note that SGLT2 inhibitor use remains very low, and very few people are getting the expert lifestyle or dietary advice, which should be the foundation of optimal holistic therapy. So if we look a little deeper on real-world data sets for ACE and ARB use in diabetes and CKD, if we look cross-sectionally, simply asking, did a person at some point in time have a prescription for one of these agents, it didn't look too bad at 70%, although it certainly be room for improvement. But when we ask the question, how many stayed on even 90 days, we see that drops off to 40%. And that's because these agents are stopped for a variety of reasons and they don't get restarted. GLP-1 and SGLT2 inhibitor use are quite low, between 5 and 10%, so the numbers are small. But if there is any difference over 90 days, it's to discontinuations or lower rates of use. And this is corroborated in another real-world study, a different sort of data. This is insurance claims data looking at medication use in persons with type 2 diabetes and chronic kidney disease. And here they plot the initiation versus the continuation rates. So again, you see another trend to more discontinuation than initiations, which means that even though these patients would benefit from these agents, most people are not receiving it, and they could only benefit from treatments they receive. So again, just emphasizing how high the discontinuation rate is relative to initiation, leading to marked underutilization of guideline-directed therapies. There are many barriers. There are patient-level barriers, for example, lack of trust in the healthcare system, clinician burnout, depends on where you live in the world about availability of medicines. Many health systems don't have guidelines for kidney care and lack support to deliver it. At the policy level, There's a lack of non-communicable disease policies really worldwide, and among them, CKD is often absent, so there really has been no prioritization regarding resources to evaluate and treat chronic kidney disease. And then, of course, at the global level, there are lots of issues with drug pricing, quality control, and if we look at prices particularly, this is from a study we published where we could find prices about 2 years ago. The retail price in US dollars for a 30-day supply at the pharmacy is highest in the United States, $550 to $690 for SGLT2 inhibitor. GLP-1 receptor agonists are even higher in the $800 to $1,200 a month range. And even with health insurance coverage, people often pay several $100s a month for these prescriptions, and they're typically on multiple meds. So even in a high-income country, these drugs are often out of reach. And even though prices are lower in other countries, depending on the area of the world, for example, in a lower-income country like India, these might still be out of reach relative to the average income. So drug pricing is a very important issue that will have to be addressed to increase access across the world. So I'll wrap up by saying that SGLT2 inhibitors, along with an ACE inhibitor or an ARB, are considered first-line guideline-directed medical therapy for persons with diabetes and CKD. GLP-1 receptor agonists and non-steroidal mineralocorticoid antagonists, based on the guidelines, are currently considered risk-based therapies for persistent albuminuria, glycemia, weight management, and cardiovascular disease. I will point out that the guideline has not yet been updated since the FLOW trial, but FLOW clearly showed that semaglutide is the first GLP-1 receptor agonist that improves true clinical outcomes for kidney disease, cardiovascular disease, and overall survival in this patient population with CKD and diabetes. But we must focus our efforts on CKD detection and access to care to remove the barriers to receiving these kidney, heart, and life-saving therapies. So we need to save kidneys, hearts, and lives, and that was the theme of World Kidney Day this year, kidney health for all, and advancing equitable access to care and optimal medication practice in all regions of the world. Thank you very much.